Welcome to this lecture. This is a review of chronic renal failure. So, acute renal failure versus chronic renal failure versus end-stage renal disease. So it is kind of a continuum, but it also can be kind of three separate things. So acute renal failure, that's something that's covered more in 285. Chronic kidney disease or chronic renal failure, a long and slow process where the kidneys lose their ability to function. And then end-stage renal disease or ESRD, truly kind of a potential outcome of chronic kidney disease when the kidneys have completely and permanently shut down. So that's end-stage renal disease. Pathophysiology. Chronic kidney disease is the progressive decline in kidney function due to the permanent loss of nephrons. So if your kidney is a spongy bunch of nephrons, and you need those to help adapt to the ebb and flow of fluids and chemicals and electrolytes in your body, and those nephrons are normally maintaining a good glomerular filtration rate, or GFR. With kidney disease, you see a gradual decline in the glomerular filtration rate because the nephrons are kind of killed off. So you lose some of that functionality. The other thing you might see is a gradual rise in the creatinine. So you actually have creatinine getting left behind in your body. It's not getting filtered out and it's rising in number. This can also be determined as a decreased creatinine clearance. So you haven't been able to clear the creatinine, so that rate or that number of clearance has actually gone down. Two different ways to look at creatinine. So signs and symptoms of chronic renal disease usually do not become evident until almost 3/4 of the kidney function is lost. So a very slow, chronic, insidious, behind-the-scenes type process. This slide is showing a map of a little bit of epidemiology of kidney failure in the U.S. I love maps. And this is showing you that the southwestern corner of the United States is having the highest incidence of chronic kidney failure. And this does correlate with diabetes. It correlates with obesity and sedentary lifestyle, some of the other maps we've seen in our course. Worldwide, we do have some hot spots of kidney disease. It'd be interesting, again, to overlay this with hypertension, diabetes, and other things that we're going to talk about in a second to see if they come together. In general, the highest rates are United States, Mexico, South America, especially Brazil, and then China, India, and Southeast Asia. Here's some famous faces with renal disease, including Sarah Hyland, who received a kidney transplant. Gary Coleman actually had 2 kidney transplants. Natalie Cole, the singer at the bottom, she had a kidney transplant. And Tracy Morgan, most recently, I think he got in a car accident, but he had actually kidney failure from diabetes, and he was a transplant recipient as well. So there's 5 stages of chronic renal disease or chronic kidney disease, stage 1 through 5. 1 is the least dangerous or the least problematic, and then 5 the most severe. And this slide and the next slide both are talking about glomerular filtration rates and how they change as this disease progresses. So normal, stage 1, kidney damage with normal or increased glomerular filtration rate greater than 90 milliliters per minute. You and I hopefully have a nice, high, fast glomerular filtration rate. So that number should be high. And then you see that number start to drop as we lose that filtrating ability, as we lose the rate of filtration. So mild reduction, moderate reduction, severe reduction, stage 4, stage 5, kidney failure. Those last 2 stages especially have the most severe damage. Now the glomerular filtration rate has dropped. In severe reduction, 15 to 29. In kidney failure, even less than 15 milliliters per minute. So that shows you that the kidneys slow down and lose their ability to process all your body waste. Same thing here, explaining the 5 stages of chronic renal failure. This talks a little bit about intervention at each stage. Stage 1, we're really looking at being preventative, trying to keep further damage from happening. Stage 4 and 5, we are truly treating for the complications of this disease, hemodialysis, peritoneal dialysis, and possibly transplantation as well. Stage 5 is complete kidney failure. Life is not sustained, and dialysis or a kidney transplant will be necessary. So the causes or etiology of chronic renal disease or chronic kidney failure. The number 1 cause is diabetic nephropathy. As blood sugars rise, microvessels become damaged. If microvessels are damaged, we lose some of the exchanges of blood and nutrients and oxygen. And in the kidneys, this is seen as a real loss of filtration in the microvasculars of the nephrons and the glomerular surfaces. So stage 1 can occur when diabetes is diagnosed. And this progresses with diabetes all the way through stage 5. So controlling blood sugar becomes key here. To prevent hyperglycemic episodes helps keep chronic kidney disease from developing, and certainly from developing at a fast rate if we had better diabetic control. The second cause of chronic renal disease is hypertension or high blood pressure. This causes, just like it would any other part of the body, an atherosclerosis, so a hardening, potentially a thickening of the vessels. They lose their elasticity and they lose their resistance. In the kidneys, this is termed nephrosclerosis instead of arteriosclerosis or atherosclerosis, but it's really the same thing, a narrowing of the vessel lumens, and this causes decreased blood flow. If you have lack of blood flow to these super porous kidney parts, you're actually probably going to put that tissue at risk for being hypoxic or losing oxygen. If your tissue becomes hypoxic, just like in the heart, you're thinking heart attack, ischemia, the same thing can happen in the kidneys. That tissue can actually become ischemic over time. The third leading cause of chronic renal disease is glomerular nephritis. Glomerular nephritis is like an infection of the glomerular tissue. So think chronic diseases, systemic diseases, autoimmune diseases, either critical infections or chronic infections over time. As the body responds to these infections by forming antibodies, antigens, this causes immune complexes to form, and they get deposited in that glomerular tissue. So if they're going to get deposited, they kind of really are just turning into scars, right? They're going to try and fight off this process. If the glomerular tissue gets scarred, then of course it loses its permeability, it loses its own exchange properties, and it just becomes much less usable. So glomerular nephritis, the number 3 cause of chronic renal disease. Why else can the kidney stop working? Well, you have some acute processes here, such as severe injury or trauma. Certain drugs are nephrotoxic. Some of the large antibiotics and whatnot can be very dangerous and harmful to the kidneys. Some congenital birth defects, as seen like with Gary Coleman, where your kidneys just may be born without the surface area or without the proper tissue to do the good cleanup that it does. Assessment of chronic renal failure. This slide is talking about things that the nurse is going to assess, both predictive, so if you had a patient you didn't quite know what was going on with them, this good assessment could give you some clues, as well as following up on a diagnosis of chronic renal disease or chronic kidney failure. You could kind of confirm your diagnosis. So we're looking for fatigue. Because the kidneys aren't generating RBCs, red blood cells, we're going to have an overall lack of oxygen capacity, so the patient will be fatigued. Headache, this is caused from changes in fluids and electrolytes. Same thing with edema. If the body's not able to process fluid out, that fluid could get left behind and cause issues in the peripheral tissues, such as edema. Could also cause issues in the circulation, such as continued high blood pressure. You may see a change in urinary frequency from a lot of urine to really tapering off, almost oliguric or lack of urine. You may see muscle cramps, numbness in fingers and toes, and some of that are really outcomes of electrolyte disturbances. Numbness in fingers and toes certainly seen as a diabetic neuropathy as well. On the right-hand side of this slide, we're looking at 10 labs that are closely correlated with chronic renal failure. BUN, looking for that to rise. Glomerular filtration rate, again, that would decline over time as the filtration rate is less effective. Albumin and microalbumin, looking for protein in the urine especially, even a serum albumin, trying to decide if the kidneys are able to handle that protein. Potassium and sodium, common electrolytes that can definitely rise with damage to the kidneys. Sodium, however, because of, if you think about that fluid getting retained, which might actually throw off that sodium level, sodium could actually be decreased or increased or normal with chronic renal failure. Phosphorus not getting excreted could be being left behind, building up in the body, causing a rise in phosphorus. Magnesium, the same thing. Look for an increase in magnesium. Calcium, you can almost look for a decrease. And then blood osmolarity, look for an increase if there is a volume depletion. So if you are taking away fluid, kind of inaccurately even, perhaps the blood could get thicker, and you can think about clotting implications as well. ABGs, the first ABG to suspect here is metabolic acidosis. Makes sense when you start thinking about the electrolytes getting out of whack, and think about how the body would respond if that were the case. So here's, on this slide, it says lab detail in chronic renal failure, just looking at those labs on their own slide here. Again, look, try and get a handle on increased, decreased levels, what's happening in the body to cause either that to stick around or get excreted, or why those levels would change. Nursing assessment of chronic renal failure. Try and guess for yourself what would happen with the blood pressure in a chronic renal failure patient. And if you think about fluid not getting processed and getting left behind and building up in the body, I would expect blood pressure to rise as a result of that. We also said that hypertension existing occurs with chronic renal failure as a risk factor. So you might have hypertension just as a historical disease as well. Heart rate, probably going to go up here as a response to that fluid overload to try and compensate. Cardiac rhythm, definitely disturbances could be predicted here. PVCs, PACs, ectopy, tachycardia, all those kind of electrolyte irritating pieces of a cardiac rhythm you may see here. Respiratory rate and effort. If you are truly in a metabolic acidosis, think about your body trying to correct itself, trying to blow off, right, and correct some of that acid. Respiratory rate would probably go up here. Effort might become more tachypnic. Obviously, maybe trying to even have some deeper breaths to blow off some of that extra CO2. Level of consciousness might change here, especially connected with sodium and some other electrolytes. If those are really getting out of whack, you may see mental status changes in your patient. Here's a graphic with some symptoms of chronic renal failure. The patient on this picture is up, walking around, but doesn't feel well. Headaches, edema, blood pressure's up. This patient's holding onto their lab slips, so reminding you that labs are going to be really starting to show up as just out of whack. Possibly a decreased ability to concentrate their urine. So you might see a polyuria where the urine's not getting concentrated. You might actually have an increased output. As the renal failure progresses, this might actually change to oliguria or lack of urine production. So diagnostic criteria, what are providers looking for this diagnosis? Well, things need to add up and kind of form a complete picture. We are looking for a glomerular filtration rate of less than 60 for 3 months or more. So again, not an isolated lab test would confirm this, but really a trend over time, a pattern of change in your patient. Documented risk factors for chronic renal failure, and again, that's diabetes, hypertension, or existing or chronic or even acute infection. Clinical symptoms for chronic renal failure, the fatigue, dyspnea, even the heart rhythm changes might show up that you would document. Urine analysis, looking for blood or especially protein in the urine, a sign that the kidneys aren't maintaining proper levels. Elevated BUN and creatinine, the same thing, those serum blood tests. And then possibly even a kidney ultrasound or biopsy, looking for structural changes, looking for areas of ischemia, looking for overall formation or malformation of the kidneys. This next slide is a graphic representation or a picture of end-stage renal failure. This patient is shown sitting in a chair. She's tired. She's really not moving around like she was. Things definitely progressing here. Increased edema, increased weakness and fatigue. Some psychological symptoms mentioned here with depression, behavior changes, certainly as a response to electrolyte imbalance, but also to a response of chronic disease and chronic treatment. You may see some lung involvement here, shortness of breath. Of course, fluid could show up in the lungs with crackles and whatnot. Deep depressed cough may be noted here. Skin changes as well. A yellow-gray color, rash, itchiness, perhaps even bruising, dryness, or flakiness. This patient has quite a few problems, all kind of coming together here at the end of renal failure. So intervention and treatment for chronic renal failure. 4 key areas on this slide. Diabetic control. We want a low HbA1c, a low glycosylated hemoglobin, less than 6.5. 2, looking up from the bottom, cardiovascular intervention and support. If hypertension is a risk factor and hypertension is also an outcome of renal failure, a complication of renal failure, we want tight control of blood pressure, tighter than probably what you're used to. So ACE inhibitors, ARBs, beta blockers, diuretics, and then of course monitoring electrolytes with those as well. Decreased albuminuria. We want to control that protein loss in the urine. So thinking about diet modification, continuing to monitor the urine to see if we can stem the loss of protein through the urine. Lifestyle changes. Number 1, smoking cessation, so linked to that atherosclerosis, so obviously with nephrosclerosis as well, the thickening of the arteries, the hardening of the artery walls. We want to increase physical activity here as much as possible. That will help some of these underlying conditions more than anything, the hypertension, diabetes, etc. And then number 1 on the top of the slide is diet and nutrition. Many different components you can control with diet, such as phosphorus, potassium, protein, sodium. You may not have the expertise as the RN, so consult your interprofessional team for help and management of the patient's diet. Treatment for chronic renal failure, especially end-stage renal disease. If you have complete failure of one or both kidneys, you will need renal replacement therapy. And renal replacement therapy can be accomplished by machine, such as hemodialysis, or by a kidney transplant. This slide is talking about the different ways to do dialysis. The machine type of dialysis is hemodialysis, where blood is perfused through a machine with actual fibrous filters to filter the blood, clean it, so to speak, and then send it back into the patient's body after the wastes have been removed via the machine. This is typically done, especially in this picture, you're seeing a fistula or a graft that would serve as that entry and exit port for the blood circulation. This could also be seen, hemodialysis, through a right internal jugular catheter, different types of ports or catheters on the body. Those are usually a little less long-term. The fistula graft might be perceived as actually being much longer term. Peritoneal dialysis, another type of dialysis, very interesting, literally putting fluids into the abdominal cavity with a certain osmotic gradient to pull off extra chemicals, extra fluid, sheerly through the process of osmosis. So depending on how that dialysate or dialysis solution is prepared, you can really start to adjust a lot of the electrolytes and so on that'll be pulled off. So that solution is usually of salts and sugars and that certain balance put into the abdomen through what looks like a PEG tube. It's actually an indwelling catheter. After a period of time when the dialysate has been in the abdominal cavity, it's simply drained via gravity, measured, recorded. The nurse is looking for how much more fluid we were able to pull off, so keeping track of volume, the color to see if you can really see some obvious wastes being filtered. Sometimes you might send a sample to the lab as well. For all dialysis patients, and especially hemodialysis patients, there are some true nursing considerations. We have to know your patient's baseline, so their target weight or dry weight, and then you're going to measure that before and after dialysis to make sure you have a handle on their fluid volume status. Medication management. This is under the role of the RN. You wouldn't infuse antibiotics or electrolyte replacement via IV and then send your patient to dialysis because they'll just get filtered out again. So a lot of times we're holding meds, we're moving med times, we're waiting until after dialysis. We may pack up a bunch of medications and send them to dialysis, especially in the acute care setting. Sometimes we'll give oral meds, sometimes we won't. So that is a good conversation to have with your provider as to how you're going to retime those treatments, those medications. It's good to talk to your patient and get a feeling for not only their level of consciousness, but how they are doing with the dialysis treatment. Many patients come back exhausted. They're tired. The rest of the day they sleep. It's like they need to reconserve all their energy. This can get a little tricky when you think of what really happened, and that was a fluid volume reduction, right? We're taking extra fluid out of their body. So there's lots of potentials there for changes in cardiovascular support, changes in fluid volume. So do assess your patient, see how they're doing with that. Are they dizzy, lightheaded, weak? Do they need a little extra oxygen? How's their blood pressure? How's their orthostatic blood pressure? Do we want them to get out of bed after dialysis, or do they need to call for help? Will they have a headache because we pulled off too much too fast? And that is actually a danger of dialysis. Pulling off too much fluid and electrolytes too fast can actually throw your patient into some pretty severe conditions. One of those is disequilibrium syndrome. So by decreasing fluid volume rapidly, you can actually kind of see it as a resultant cerebral edema or increased intracranial pressure. This can happen during dialysis. This could happen when it gets back to you on the acute care unit. By the time you would see a seizure or a real change in level of consciousness, that's a very late sign. So we don't want that to ever happen. The treatment for this, the way to keep this from happening, is focused on prevention. Communicating with dialysis, the dialysis nurses, be it inpatient or at a freestanding facility or even a home unit, starting slow, doing it for short periods rather than a marathon session, and really balancing out that treatment. Nursing care of the dialysis graft and fistula. We want to protect that site. A lot of work was done to actually harvest a vein and flip it around and make like a new entry port, so we want to protect it. No blood pressure on that arm, no IV starts, no blood draws. Definitely want to palpate for a thrill and auscultate for a bruit. Make sure we're having good blood flow. And blood flow includes checking pulses in that site, above and below, and especially distal to that site. Range of motion to keep the blood flow adequate. Make sure that your patient's protecting that site by not lifting heavy objects, not wearing constricting things on that arm, such as a really tight watch band, a compression sleeve like you might see with some athletic clothing, and not sleeping or putting pressure on that arm. Some complications of chronic renal failure that can happen over time. One is anemia, shown here at the bottom left of this slide. Anemia because the kidneys aren't producing that erythropoietin. So the treatment might be to help out the body with producing those RBCs. Might be injecting some erythropoietin. You can actually have mineral and bone disorders. If phosphorus and calcium are being affected, we might want to do some control there with diet and whatnot, or maybe even medications. For example, if the phosphate's not getting filtered out and getting left behind in the body, we don't want that to cause trouble. So we're going to give a pill, for example, Renagel or Salemivir. It's a big capsule, kind of tan in color, and that'll help bind literally to the phosphate, either to render it inert or to help it be excreted safely through the stool. So different ways to balance out some of these minerals and electrolytes. You can also see that being done with diet. For example, to control phosphate, go to a very plain renal diet, which may include bread, pasta, rice, fruits, and vegetables. Those are all low phosphate foods. High phosphate foods to avoid: beans, lentils, nuts, and high dairy and meat. So again, work with your dietitian to not only balance those nutrients, but also to prevent malnutrition. Malnutrition here is on the upper right of this slide. So as glomerular filtration rate decreases, you may actually see kind of a resultant anorexia. It's like they're not getting the benefit of the nutrients to the body. So maintaining a calorie count, encouraging definitely intake, and working with a dietitian. Prevention of dyslipidemia is seen on this slide in the middle right-hand column. Knowing that cardiovascular disease is a contributing factor and also even almost an outcome of this condition, we really want to control their cardiovascular risk factors. Treating hypertension we've mentioned, but also treat their cholesterol. Looking at HDLs, LDLs, another call here for exercise to increase HDLs, and diet to control LDLs. These patients may get started on a statin and even some aspirin or other anticoagulation. And then last, on the bottom right of the screen, we're looking at depression. Mental status changes, not only because of electrolyte imbalance and chemicals, but also because of the chronic nature of this disease, the long treatment, the disability that goes along with being tethered to long periods of treatment, and so on. This slide is a review slide just reminding you that the kidneys can actually, in chronic renal failure, have a resultant anemia because they are not producing erythropoietin, which you need to make red blood cells. Those red blood cells that carry oxygen, if you don't have enough, if they're not coming from the kidneys, your patient could show signs and symptoms of anemia. So renal transplantation, another treatment for renal failure. Again, just a quick review that the kidney is harvested from a healthy donor or perhaps even a cadaver donor and implanted into the recipient while the other kidneys remain intact. This is a match that takes probably several months, maybe even several years. They do a lot of matching of these organs by not only blood type, but also some antigens and some genetic matching, trying to get the best fit as possible. These patients will probably stay in your acute care facility for at least a week. The donor usually not as long, but the recipient definitely longer, and looking, of course, for any complications. One complication that can arise from renal transplant or any organ transplant is rejection. Rejection, if your body decides that it will not continue to accept this organ tissue, you will know it. Your patient will appear sick, and they will appear sick quickly. All signs and symptoms of rejection can include almost signs and symptoms of like a massive infection. Think of it as your body rebelling, just like it would with an infectious disease. Fever, soreness, pain in the organ area, decreased urine output, especially with this kidney. These patients will come from surgery and they will be on immunosuppressant medications to keep this from happening. And those immunosuppressive medications, they'll need to be on for the rest of their life. So we already know that the immune system is definitely at risk here. Signs and symptoms of rejection. If the patient's going to lose their kidney, they would absolutely have to be in an acute care facility and hopefully even like a major trauma center where they could actually have surgery. They will probably remove the offending organ. Kidney patients in particular would need to go back on dialysis if they would lose the kidney. 2 videos here for you to watch if you'd like to review. They total about 6 minutes. One is Ayanti Brown, a young lady who talks about her life on dialysis after losing her transplanted kidney and how now she is facing the wait for another kidney. And then Ben Gray is an active man who talks about his kidney failure as a result of uncontrolled diabetes. Priority nursing problems here. Excess fluid volume we've mentioned several times. Risk for decreased cardiac output related to, obviously, the heart not working as it should, along with the fluid changes and changes in stroke volume, changes in electrolytes, and so on. Lots of good assessment here to think about for both of those. Jugular vein distension, lung sounds, cap refill and edema checks, looking at skin, temperature, color, etc. And then the last one here is impaired urinary elimination. Another nod to for the nurse intervention here to good I&O, looking at lab values, monitoring changes, and of course notifying the provider with any serious results. This concludes our lecture on chronic renal failure.